Bismillahirrahmanirrahim. Dear student, we will continue the histology of oropharynx. Now, in this region, we will continue with the histology of pharynx. Now, in this slide, you see H&E stain of the cut section of the pharynx. Same pattern of GIT, mucosa, submucosa, muscle layer, adventitia, or serosa. The epithelium is certified squamous, non-keratinized. Certified squamous, non-keratinized because it is the pharynx, smooth in outline. Smooth in outline, basal layer resting on a basal lamina, then the surface layer is squamous type of cell. Then you see the lamina propria. In this case, the prominent elastic fibers are there. Why the nature has provided this elastic fiber? Because of the tissue become more elastic, stretchable, because the incoming bolus or food particle, they may thrusting in nature, may enlarge the tube, so nature has given it a added capacity to become dilate. So there is the dilatation as well as reduction in the lumen of the pharynx. So this elastic tissue is prominent feature present in the lamina propria. In the muscle layer, you all know that the pharynx, they are all of the muscle which are of skeletal type, because the pharyngeal muscle, constrictor muscle, then the superior constrictor, middle constrictor, inferior constrictor, many other surrounding muscle. So all these muscles are the skeletal in nature. They are under the voluntary control. Invariably, you see also the salivary gland, which are the scattered islets of the salivary glands are present. In between the salivary gland, you see multiple blood vessels, lymphatic tissue, as well as the scattered nerve plexus. So this all is the skeletal muscle in cut section. So in the pharynx, you will see skeletal muscle, that is the nuclei at the periphery, and they are elongated ribbon-like structure of the muscle fiber. Sometimes cross striation also be visible in high power, and salivary glands are also visible in this diagram you see. Now, what is the nasal mucosa? So nasopharynx, the nasal mucosa, it is the respiratory epithelium. The characteristic feature of the respiratory epithelium is the pseudo-stratified columnar ciliated epithelium. This is the best picture of the pseudo-stratified columnar ciliated epithelium. All types of cells are visible. Goblet cell full of mucous granule, pear shape. The apical cell, which show the cilia, which are the very significant value on the surface projection of the columnar cell. They are meant for the propulsion and evacuation of the sputum or any secretion present within the nasal mucosa. The basal cell are low-cuboidal or pear shape. Then nuclei at various levels. So appearance, that is the multi-layered, but actually it is a single layer, pseudo-stratified columnar ciliated. In the lamina propria, you see they are the loose connective tissue, capillary plexus with erythrocyte, and all the structure which are visible, that is the collagen fiber, elastic fibers, as well as the blood vessel nerve plexus. This is the typical epithelium of nasal mucosa. Once again, concentrate on this. The pseudo-stratified columnar ciliated, cilia prominent, goblet cell prominent, nuclei at variable level, all the cells resting on the basal lamina. Now the laryngopharynx, This is anatomy of the laryngopharynx. So laryngeal inlet, interretinoid notch. Then the mucosa is the same, but the epithelium is pseudostratified columnar epithelium. Extend from the upper border of the epiglottis to the lower border of the cricoid cartilage. Laryngeal inlet, posterior surface of the cricoid retinoid cartilage form the boundary. Common site of carcinoma in female and Plummer-Vinson syndrome, PV syndrome, the common site over here. Laryngopharynx, this is the anatomy parts of the laryngopharynx. It is also called as hypo-pharynx. Now, what is the epiglottis? Now, epiglottis, you know the anatomy, that is the slit-like structure, which is the valve-like pattern, give way to the air to the properly trachea and food particle to the esophagus. It is act as a liver or a lid-like structure. In this case, the epiglottis is important because of histologically, because it has a double epithelium. The surface, which is related with the posterior surface of the tongue, aryepiglottic fold, and the surface related with the tongue, the epithelium is stratified squamous, keratinized over here. In some patches, keratinization, but usually stratified squamous, epithelium non-keratinized, but in patches at the apex, because there is a constant friction over there. So when friction is there, the nature has provided a protective mechanism of keratin layer over there. But epithelium usually it is stratified squamous on the glottic or the tongue side. Then the lamina propria, same feature, that is the loose irregular tissue with scattered acini of the mucus type cell. Then is the cartilage, which is the elastic cartilage. Elastic cartilage is important because this lid-like structure is highly elastic. Flexibility. It moves down to close the tracheal opening. It moves up to open the trachea. So opening and closing phenomena of the epiglottis is important. For this, nature has provided the elastic cartilage. All the feature of elastic cartilage: chondrocyte, territorial matrix, interterritorial matrix, then the perichondrium membrane. Then is again a serosa, that is not serosa, but it is lamina propria. Next fourth layer is again the lamina propria. This lamina propria again contains the serous acini, loose connective tissue, and then toward the laryngeal side, through the larynx, the epithelium will change, pseudostratified columnar ciliated epithelium. So double epithelium, double lamina propria, sandwich is the elastic cartilage. So this is the typical feature of epiglottis. Usually this is asked in the Viva as well as the UHS exam system, because it is important slide. You will have to memorize it. So this is the histological picture, H&E stain of elastic cartilage, this stain of the epiglottic tissue. Now, this is the laryngeal side, which is pseudostratified columnar ciliated. Then is the mucous and serous glands in the lamina propria. Then this is the elastic cartilage containing chondrocyte, perichondrium on both sides. And then is the lamina propria again present. Then is the epithelium toward the oral side is visible as stratified squamous, non-keratinized. This is the lingual surface toward the tongue. Lingual surface, stratified squamous, non-keratinized. At some places it is keratinized also. So this picture will again memorize or remember you to layers 1, 2, 3, 4, and 5. You would have to memorize. Double epithelium, double lamina propria with elastic cartilage is the characteristic feature of epiglottis. Now the hypopharynx means the upper part of the esophagus. When the food particle or bolus slide through the epiglottis toward the esophagus, the part is the hypopharynx. Characteristic feature pseudostratified columnar pseudostratified squamous epithelium visible in this slide, H&E stain. The lymphocytes are prominent. Now lymphocytes are becoming nodular form. Nodular form, again a mechanism of protective mechanism. So lymphocytes are prominent in lamina propria. The muscle is still in the stratified schema. The muscle is skeletal in nature. Now in this diagram, the submucosa is also present. The submucosa is the part which consists of dental connective tissue with blood vessel, and then the nerve plexus is also visible. So the muscle will be of skeletal, not smooth. So always remember, in the hypopharynx, still the muscles are characteristically skeletal in nature, controlled by the voluntary or the somatic nerve fibers. Epithelium again is the stratified squamous, non-keratinized. Now we come to the esophagus, proper tube of the GIT. So this upper one third of the esophagus, it consists of mucosa, submucosa, muscularis externa, adventitia. Mucosa, submucosa, muscularis externa, adventitia. Now epithelium is stratified squamous, non-keratinized. Look at the picture. You know the mucosa consists of the surface epithelium, lamina propria, and muscularis mucosae. These three structures constitute the mucosa. The mucosa in the upper esophagus consists of stratified squamous, non-keratinized. Then is the lamina propria. So lamina propria consisting of the loose tissue with fibroblast. Then is the blood vessel, fibroblast. Then is the blood vessel along with the nerve plexus also visible. All the cells present, collagen fibers, elastic fibers are also visible. Then the muscularis mucosae. Now this muscularis mucosae give first appearance in the upper part of the esophagus, and this muscularis mucosae is always and always, remember, it is the smooth muscle, not the skeleton. It is smooth muscle, it is involuntary muscle. The purpose of this location of this muscularis mucosae is because of the maintenance of the internal lumen of the viscera. So luminal properties is maintained by the muscularis mucosae because it, when contract, it reduces the lumen. When it dilates, when it relaxes, the lumen become dilated. So it is controlling property, giving muscularis mucosae to the luminal viscera. Then we come to the submucosa. Now submucosa contain collagen fiber, elastic fiber, and mucus gland, quite visible. So these are the numerous mucus glands present in the submucosa. So in the lamina propria, no gland, but in the submucosa you see a esophageal gland as well, which is meant for the lubrication of the luminal side, because the incoming bolus to facilitate the propulsion of the incoming food particle toward the luminal side, toward the stomach. So the muscle layer is the skeletal muscle. Always remember, not visible in distal eye, but the muscle layer is the muscularis externa, the skeleton in type. Always remember the skeleton type in upper one third of esophagus. It is voluntary muscle. So it is controlled by your will, or somatic innervation is the controlling of the skeletal muscle. The outermost is adventitia, which is made up of collagen fiber and elastic fiber and blood vessel. Not the serosa. Serosa is the peritoneal lining in the upper esophagus. It is the adventitia. There is no peritoneum over there in the upper esophagus one third. So the adventitia is the space provided outside the esophagus, also give the attachment to the esophagus, to the surrounding structure, consisting of the collagen, elastic fibers, and blood vessel. Middle third of the esophagus, again the mucosa, submucosa, muscularis externa, adventitia. Now, mucosa is the stratified squamous non-keratinized epithelium. This is the lumen of the esophagus, stratified squamous non-keratinized. This is the lamina propria. This one is the muscularis mucosa. You see scattered smooth muscle cell which surround the luminance of the esophagus, and the lamina propria consisting of the blood vessel, the nerve plexus, and the collagen and elastic fibers. The muscularis mucosa again is present, the feature of the mucosa. So again present in the middle third. Then the mucosa is consisting of the dense irregular connective tissue beneath the submucosa, beneath the muscularis mucosa. Then is the muscle layer. Muscle layer are of two types: upper 1/3 skeletal muscle, middle 1/3 mix, and lower 1/3 is the smooth fibers. So double muscle layer. In some places it will become skeletal, and in some places it become smooth in type. So both the muscle variety, skeletal as well as smooth, are present in the middle third of the esophagus. The adventitia is the loose areolar connective tissue. Still the serous lining is not present because the peritoneum is not attached on the this esophagus in the middle third. So the outermost covering is the adventitia. This is the middle third part. The lower third is the esophagus. Now in this diagram, this is the handwritten diagram, and this is the histological picture. So it is a Chinese stain. So stratified squamous epithelium, lamina propria, muscularis mucosa, lamina propria, all the features of connective tissue, muscularis mucosa. The submucosa contain the mucous gland that is present in the submucosa, blood vessel, fibroblasts, collagen, and elastic fibers. And then the muscles in this case now in lower esophagus is smooth, no skeletal element. Now look at a picture. So these muscles are smooth, that the spindle-shaped muscle, central nucleus in the form of a sheet. The outermost covering is the tunica muscularis, which is longitudinally cut. This is the longitudinal cut, this is the transversely arranged muscle fiber, and the outermost is the serosa. Outermost in this case is now serosa, because the lower 1/3 of the esophagus is covered by the peritoneum of the gastric gland, that is the stomach. So the peritoneum is covering in lower part, so it will be outermost covering, that will be of serosa, containing the connective tissue with the squamous cell outermost. Squamous cell, which is known as the mesothelium. It is known as the mesothelium. Simple squamous epithelium with underlying few connective tissue elements are present. So this is the simple squamous epithelium. This is called as the mesothelium. This is the histological picture. Actually stain, stratified squamous epithelium, lamina propria, muscularis mucosa, then is deep submucosa, deep connective tissue, and all the layers will be visible in the lower esophagus. Now what are the clinical aspects of this histological picture of all these the organs? Abnormal change in the epithelial system or the epithelial tissue in the lower portion of the esophagus is called as metaplasia. Now you all know that the lower part of the esophagus is the stratified squamous epithelium. When it is replaced by the replacement of normal epithelium, that is stratified squamous epithelium lining of the esophagus, by simple columnar epithelium with goblet cell. Now always remember, it is called as metaplastic change. When the lining epithelium is changed from stratified squamous to simple columnar with goblet cell. Esophageal adenocarcinoma, a very often deadly cancer because of which it is considered to be a pre-malignant condition. So this metaplastic change is also called as a pre-malignant condition. The main causes of Barrett esophagus is thought to be a adaptation of chronic acid exposure from the reflux esophagitis. Now, Barrett esophagus is nothing but is the metaplastic change in the lower one-third of the esophagus due to the change in the epithelium from stratified squamous to the simple columnar with goblet cell. It is also thought by the precancerous, pre-malignant condition. The cause is constant reflux esophagitis, which is seen in some patients. Now look at the picture. So this is the lower esophagus. Now there is hyperemia, that is congestion in the lower one-third. This congestion feature is due to the presence of changed epithelium. This one is the normal epithelium, the stratified squamous non-keratinized. This is the simple columnar epithelium. Look at the picture difference. Same is the case. Now this is simple columnar epithelium. This is simple stratified squamous epithelium. This is simple columnar with goblet cell when it is changed. So this is the intestinal metaplastic change. Intestinal epithelium will move toward the lower part of the esophagus. This is the precancerous. It is called as a Barrett esophagus. This phenomenon is called as a Barrett esophagus. So it may lead to cardia eclasia as well. It may lead into the cardia eclasia. Now inshallah we move next in the lecture, stomach. So this is today sufficient. Thank you very much.